Hello, I am Dr. Deneishia Fisher, OB Hospitalist and Site Director for Ob Hospitalist Group in Virginia. I want to tell you a story about a patient I had an opportunity of caring for recently. She presented to our OB-ED at 36 weeks complaining of leaking fluid. Initially, she was evaluated by our OB hospitalist midwife and was admitted to labor and delivery after she had indeed confirmed that the patient had broken her water. A few hours later, her nurse called me requesting that I come to her bedside immediately to evaluate her. She said the patient had a sudden gush of bright red blood, severe abdominal pain, and the fetal heart rate was in the 60s. Hearing the urgency in her voice, I jogged down to labor room 5 to find the patient writhing in pain. And the fetal heart rate at that time was in the 60s. I evaluated the patient and looked at the pad, and there was a large amount of bright red blood on her chuck pad. I did a vaginal exam only to find that she was 5 centimeters and she had a slow trickle of bright red blood from the vagina. I applied a fetal scalp electrode, which is a small device that we attach to the scalp to get a more accurate fetal heart rate. The fetal heart rate at that time was now in the 50s and it had been low for several minutes now. Due to the patient's pain and the bleeding, and while looking at the monitor, seeing that she was contracting almost continuously, I suspected that she was having what we call a placental abruption or a premature separation of the placenta. It was separating from the wall, and that's why she was bleeding and having so much pain. At that time, I called a cold gold, which in our hospital is an emergency C-section. Our team quickly was able to transfer the patient from her labor and delivery room to the operating room for me to perform an emergency cesarean section. The anesthesiologists and neonatologists met us there. The neonatologist efficiently placed her under general anesthesia, and my assistant and I began the emergency C-section. Upon entering the uterus, there was bright red blood and large clots, even before we can enter the amniotic sac. Once we broke the water and delivered the baby was very limp and very flaccid. We quickly clamped and cut the cord and handed the baby to the pediatricians and neonatology team. At this time, we all took a deep breath and clamped the cord to obtain a blood gas sample. Unfortunately, the cord had no cushion around it. It was very thin. It was about the diameter of a drinking straw, which was extremely thin for a near-term baby. Unfortunately, the team was not able to obtain the cord blood gas because the cord was almost completely drained of blood. It was thin and it was pale. Fortunately, the baby did well, although the baby had to go to the NICU for a period of time. The baby did well, and so did the mother. It is situations like this I'm very thankful for being an OB hospitalist. These emergencies, this is a true medical emergency, and times like this shows the value of having an OB hospitalist on our unit. The patient's primary doctor was in his office. He was 15 minutes away. And because I was there and available, fortunately, this mom and baby did very well. I'm thankful to be in a position to partner with our nurses and our community doctors to provide sometimes life-saving care to our patients. At the end of the day, we want healthy moms and healthy babies. And I think as OB hospitalists and our OB hospitalist midwives, we're able to make sure that at the end of the day, we have healthy moms and healthy babies.